Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good morning to all participants, pathologists and all the participants lah. So basically, the topic or the cases that I will share today is more on topic of differentiating mucinous, papillary and low-grade lesions of the breast in cytology. But the cases is all the cases that I'm doing head attachment in Sungai Petani lah. Alright, so we go to outline of my presentation. Basically, a little bit on introduction. The reporting system of breast cytopathology, approach to interpretation of breast finding the aspiration biopsy, and then I will proceed to sharing cases, 4 cases from Hospital Sungai Petani. Alright. So a bit on introduction. Nowadays, the breast lesion are one of the most common pathologies encountered by us as a pathologist lah. And this is due to increased awareness of the breast cancers that lead to an increased self-detection lesion. So because of this is a kind of pathologist nightmare when, of course, when we're dealing with breast cytology, particularly in a wide variety of papillary lesion, a sclerosing lesion like sclerosing adenosis, radial scar, sclerosing fibroadenoma, and low-grade malignancies like tubular carcinoma, lobular, and as well as mucinous carcinoma. And all those mentioned carcinoma actually provide the highest false negative diagnosis when they are aspirated, in combination with also monomorphic ductal carcinoma in the elderly. So the trend of core-needle biopsy is now increasing. So FNAC versus core-needle biopsy. So actually, who wins the match? It's not actually the issue of winning the match, but both combination of FNAC and core-needle biopsy are important diagnostic modalities and actually complementary to each others. So far up to date, there is no single guideline to which pathological test is to be used for pre-operative diagnosis. In general, basically, if clinical and radiological assessment are indicative of benign lesion, it is better to opt for FNAC. But for non-palpable lesion or lesion with micro-classification, it's better to opt for core-needle biopsy. This is mentioned in this journal. So for reporting system of breast cytopathology, this is the that we are using currently based on the National Consensus 1996, which the reporting based on the category of coding. Coding, that is the code of C1 for the inadequate, C2 for benign, and C3 for atypical, probably benign, C4 for suspicious favor malignancy, and C5 for malignant. So the previous, the current system that we are using actually lack of standardization, more issues on the inadequacy or adequacy of the lesion of the sample. So it's remained an enigma until that makes the IAC make an initiative to produce a new system just like the other system. So now they are producing the new system, which is the Yokohama system, whereby the consensus were made based by the pathologists, radiologists, oncologists, as well as the surgeons. So they are also utilizing all the 5 categories, the same 5 categories, based on the same coding system with the little bit changes for the criteria of insufficient or inadequate. But the rest of the criteria for benign, atypical, and suspicious of malignancy and malignant, they did provide the guidance or guideline for in order to standardize the reporting pattern and to help and guide pathologists in cases of any ambiguity, cytology features are present. So for insufficient or inadequate, basically they define the smears that are too sparsely cellular or too poorly smeared, or anything that related to fixation that unable to proceed with cytomorphological diagnosis. Now, a minimum number of epithelial cells is no more required for a sample to be adequate, as long as the cytology finding is correlate well with clinical and the radiological finding. However, they also recommend that in cases of solid mass identified radiologically, they also recommend that we need to quantify a minimum of 6 to 7 epithelial tissue fragments, which consists of at least 10 to 20 cells. It's still recommended for us as a measure for sample adequacy before we proceed with benign diagnosis. This is just to ensure that the tissue fragment architecture and myoepithelial cells are able to assess in that case. So this is, I just simplify the approach to interpretation of breast FNAC, which is, it can be used in the case that we will be discussing after this. So first is the cellularity. The second one is based on the architectural tissue pattern, and the third one is the background material. So for cellularity, it is based on the summation of the material present in all of the slides, and it is usually relates to the epithelial cells component only. It can be described as scanty, low, moderate, or high. And after that, the assessment of the architectural tissue pattern. Okay, the assessment can be done under low power. So we need to describe regarding the shape and size of the epithelial and stromal tissue component, whether it large or small, crowded, overlapping. And then after that, we need to mention about any presence or absence of myoepithelial cells, and then any pattern of dispersals or single cell pattern in the background. If any, we need to describe their NC ratio and the degree of cellular atypia that present. And after that, we need to evaluate the background material, whether it is cystic or finely granular, proteinaceous background, presence of fibromyxoid, fibrillary or sclerotic background, presence of mucinous material, or any necrotic debris present. So we go to the case number 1. This is a 29 years old female with left breast lump for 3 weeks. The lesion is less than 1 cm, and they've performed FNAC. So this is under low power assessment. Basically, the cellularity is not that great, but we can appreciate a few groups of epithelial cells that a bit loosely cohesive, and scattered bare nuclei can be appreciated at the background. So this is under higher power. We see closely at the clusters of the groups of the epithelial cell. It's still cohesive. Okay, still cohesive, and the cell a bit bland looking. Okay, so bland looking and quite uniform. Okay, and if you can appreciate, as shown by the arrow, there is presence of transversing blood vessels. The red arrow, okay, presence of transversing blood vessels associated with the cell clusters. And the triangle, the green triangle indicating, or just to show you the bare nuclei in the background. So this is the other view. The other view, even though it's not very cellular, but the other view shows cohesive ductal epithelial cells with overlying intermingled myoepithelial cells can be seen, even though it is quite thick and we cannot really appreciate, but we can see the cells at the periphery. Okay, and the other one is just to highlight you the branching capillary blood vessels. Okay, if you can see, and then the background of stromal matrix. Okay, and it could be mucin, it can be background fibromyxoid material. Okay, so this is the air dried, alcohol fixed smears. So the other views shows groups of cells really cohesive. It is still cohesive, tightly cohesive, with presence of myoepithelial cells. Okay, and some this group shows branching hyperplastic fragments of ductal cells. Okay, so the red arrow highlighting you the myoepithelial cells, just to show you the myoepithelial cells that intermingle together with that blend together with the ductal cells. Okay, so based on that feature, the cytology diagnosis was benign. So what are the possible differential diagnosis for this lesion? So overall, if we follow the cellularity, the architectural pattern and the background, so the pattern more of benign, okay? The pattern more of benign, but with the presence of background material, the other differential diagnosis is mucosa-like lesion is still possible. Is also possible, even though it is rare. So they put as diagnosis of in favor of mucosa-like lesion with differential diagnosis of fibroadenoma. So just to show you, to apply the criteria of cellularity, architectural tissue fragment, and the background background material, just like I mentioned just now. So radiologically, they did after that, it shows a well-defined hypoechoic lesion measuring about less than 0.5 cm, and there's no features of suspicious features. So their interpretation is benign breast lesion. So after that, they receive HPE, is a well circumscribed lesion about 2 centimeter of size, and it shows very typical very typical proliferation of the duct epithelial as well as the stromal component. So if you can see the stromal is so fibromyxoids with the ductal with the epithelial element proliferating the pericanalicular as well as the intracanalicular pattern. And the other view shows the lesion is well circumscribed, covered by a thin fibrous capsule. So the HPE diagnosis is fibroadenoma. So for benign Yokohama system, what is the criteria? So the criteria, by definition, it is the diagnosis that should be made where there is unequivocal benign cytologic feature, even though they may or may not be diagnostic for a specific benign lesion. And the risk of malignancy is about 1.4 to 2.3%, even though the risk of malignancy is very difficult to establish because they said most of the cases is not going for surgery. However, they said that imaging or clinical negative follow-up up to 6 to 12 months is actually sufficient to say that this is the assessment triple negative diagnosis is negative. So just to ensure that the finding the expression diagnosis is correct. However, if any clinical or imaging is suspicious or indeterminate, they suggest for repeat FNA or corneal biopsy. So we go a bit to about mucosa-like lesion. So these mucosa-like tumors are a synonymous term, and they actually rare lesion of the breast. They were first described by Rosen in 1986 as a benign cyst lined by flat or low cuboidal epithelium filled with mucin, with or without extravasation of the mucin into the surrounding tissue. So the lesion is almost similar to mucosa. And this lesion is also associated with ductal hyperplasia, atypical ductal hyperplasia, or cribriform and micropapillary types of intraductal carcinoma. So these findings support the concept that the mucosa-like lesion of the breast may present as a spectrum from simple mucosa-like lesion to mucosa-like lesion with DCIS. So because of the frequent association with atypical ductal hyperplasia and ductal carcinoma in situ, this type of lesion is suggested to be a precursor of mucinous carcinoma as well. So how to differentiate? As mentioned, always we need to apply triple test or triple approach, whereby we need to have together constellation finding of the clinical radiology as well as cytological finding. And usually this kind of lesion usually occur in younger women as compared to the mucinous carcinoma type usually occur in the older person. And radiologically, it says that it shows a different distinct radiological features. Okay, so how it is differentiated? Based on the radiologically, generally mucosal lesion is more cystic rather than solid in mucinous carcinoma. However, in mucosal lesion, even though it's cystic, it can also shows, in few cases also can shows thickening or irregular or well-defined nodules can be appreciated that makes the clinical diagnosis further difficult. So that's why they need us for ni lah, for confirmation. So this article actually described regarding cytological features in mucosal lesion as well as mucinous carcinoma. So the features that they review based on the cases that they review, they isolate a few features like mucin amount, cellularity, dissociation of the cells, cell arrangement, intermingled myoepithelial cells, naked bipolar nuclei, the chromatin cells, the chromatin pattern of the cells. Basically, if we read in details, it's not really different. It's not really helpful to differentiate depending on the case. But in general, cellularity and the cells and presence of myoepithelial cells, it can suggest benignity or malignant diagnosis. So why we need to differentiate? Because of the management, of course, is definitely different. Mucinous carcinoma, usually they need sentinel node biopsy. As for mucosal lesion, the lesion is usually they need to excise. So the cytomorphologic challenges, as I mentioned from the previous table, is very difficult, especially in the cases where it shows three-dimensional clusters, the cell with nuclear hypochromasia and hypocellular, the smears is also hypocellular, and the nuclear feature is also low grade. So these are the challenges that we need to face, and we need to be cautious when handling this kind of cases. So as a general important features for mucinous lesion favoring benign rather than carcinoma in general, based on the clinical, the patient usually younger age group with and the radiologically the lesion generally is cystic in on ultrasound. Okay, and in cytologically in cytology usually the cellularity is not that great. There is no or rare single intact tumor cells, and the cells usually arranged in flat sheets with absence of significant nuclear atypia. This is identified by this author. So we go to the next case. This case is 79 years old Indian woman with 3-month history of right breast lump. It's about 2 by 2 cm and they proceed with FNAC. So we go to this case. What we can appreciate is that the most striking features is the background is so magenta colored, material is so obvious, okay? And the dark blue colored background is the cellular component. So so we try to apply based on cellularity. So cellularity is quite high, moderate to high, and the architectural tissue pattern, as we can see, there is quite numerous, dispersed irregular large tissue fragments. Okay, you can see also the cells that singly dispersed, as highlighted by the arrow. Okay, you can see the area where the cell are singly dispersed, and also in the large irregular fragments. So this is the alcohol fixed smear. You can see the same material can still be appreciated, and the fragments of tissues, the tissue fragments are quite large with some looks like papillary-like clusters. Okay. So we go under higher power, we can appreciate these areas as shown by the arrow. Okay, the green arrow, you can see that the transversing blood vessels, presence of transversing blood vessels, associated with the cells. So the pattern of the cell is also quite dispersed with single intact cells are present in the background. Hardly we can see any bare nuclei or myoepithelial cells in the background or associated with the tumor cells. So this is the papillary fragments. So these papillary light fragments, because the core is not really can be appreciated, you can see that this is possible core here. So it looks like the papillary fragments, and the lining epithelium is more of columnar type. So this is under higher power view to show you the pleomorphism of the cells. Okay, nuclear pleomorphism is quite moderate, quite mild to moderate, with presence of mitosis. Okay, and then you can appreciate the nucleoli. Okay, the cell with nucleoli. Okay, and the other view, really difficult to see, but here you can appreciate the intracytoplasmic vacuoles. So, applying that three criteria just now, so the features more of definitely malignant pattern architectural features. So the reported as features are consistent with mucinous breast carcinoma. So as I mentioned, we need to apply the cellularity, the architectural tissue pattern, and also the background material. So radiologically, the lesion is well defined, and with measuring about 2 centimeter with focal architectural destruction seen laterally. And mammographically also the lesion is well defined with only minimal architectural destruction are present. So they also radiologically also suspicious of malignancy lah. So after that they receive the HPE. They proceed with mastectomy with axillary clearance. So this is the typical finding of clusters of epithelial cells floating in the island of mucin. So this is the most of the areas shows this kind of pattern. Okay, in these areas we can appreciate the neoplastic cells are present in micropapillary type pattern with some of the cells in sheets. Okay, so the diagnosis was mucinous carcinoma based on the histology. So we see what is the Yokohama system say about the definition of malignant. The malignant it should be unequivocal. It should be definitely malignant, and if possible, the type of malignant identified should be stated. So what are the key cytologic features for mucinous carcinoma? First one is the criteria based on cellularity. Cellularity is high, and what are the architectural tissue pattern? Tissue fragments is irregular with mild to moderate epithelium and with presence of occasional intracytoplasmic vacuoles, and we can also appreciate that myoepithelial cells very nuclei are full, and there also presence of branching anastomosing capillarity. But this is not the differentiating features, because we also can see on the benign lesion just now, as I shown the first case before. So background, it should be of mucin. So just to recapitulate an important point for mucinous carcinoma, it is a rare breast tumors accounting for 1 to 7% of all invasive breast cancers, characterized by the presence of abundant extracellular mucin, should be more than 50%, separated by a fibrous septate containing capillaries. It's more prevalent in women of older age. Generally, it's of low and intermediate grade with low mitotic rate. Typically, this hormone receptor is positive and HER2 is negative. It is a favorable prognosis with low rate of regional nodal involvement. So the subtype of mucinous carcinoma based on cellularity as well as based on the mucin proportion. For cellularity type, is known as type A, whereby the tumor is hypocellular with ribbon, annular, and cribriform growth pattern. And in type B, it is highly cellular tumor with clump and sheet-like growth pattern, less extracellular mucin, and typically with neuroendocrine differentiation. And based on mucin proportion, it is pure mucinous tumor when the mucin is more than 90%. and it is mixed when the mucin component is about 50 to 90%, and less than, and any component of less than 10% mucin also should be mentioned. And pure mucinous tumor may also have foci of micropapillary pattern, which is consists of moral-like clusters that possible reminiscent of invasive micropapillary carcinoma. So we proceed to case number 3. This is the 23-year-old female presented with bloody nipple discharge since 2018. However, cytology examination at that time was negative for malignancy, and she was subsequently followed up and noted to have right breast lump measuring less than 1 centimeter. FNAC was performed that time, however, the result was unsatisfactory. Subsequent record of follow-up was not available, and she defaulted, and again she presented with a bloody nipple discharge in August 2020. So this nipple discharge was sent for cytology examination. Sorry, so basically this is cytology. The discharge sample was taken from the nipple. So basically the cellularity is very significantly low with the background of hemorrhage. What we can appreciate is only occasional ductal, occasional epithelial cell with occasional formihistiocyte, as I highlighted in the higher power image. Okay, so the cells, okay, cellularity is very low. Okay, we can see that the other image of the cells shows a very cohesive groups of papillary-like clusters, and the cells shows nuclear enlargement. Okay, however, the NC ratio is not really prominent. Okay, not really high. It's still low. Okay, and the cells are still cohesive, and rarely we can see any bare nuclei in the background. The background is hemorrhagic, and if you can appreciate, there is an occasional cell with eccentric nucleoli. Okay, eccentric nuclei. This is from other fragment. It's a very dense tissue fragment. It's probably papillary-like, but we hardly can differentiate any fibrovascular core. Okay, this is the clusters of cell with scalloping edge, and if you can appreciate the cell molding at the periphery of the edges. Okay, this is another groups of cells. It's still tightly cohesive, and there is scattered siderophages or formimicrophages present in the background. So based on that finding, cellularity is low, but the architectural and pattern of the cell, it shows overlapping features, which is papillary-like structures, which also can be seen in malignant. Therefore, the atypical diagnosis is appropriate to be put in this kind of diagnosis. So they also request for tissue biopsy for histology evaluation. So what basically to highlight you, there is the architectural atypia is more prominent rather than the cytology cytomorphological atypia in this case. So they proceed with ultrasound. It shows that single dilated right retroareolar duct with soft tissue lesion. So the differential at that time include ductal papilloma. So since single duct involvement, so they proceed with right microdocectomy. So this is the histology of the image, histology image of the case. So if you can appreciate the arborescent structures of epithelial tissue, okay, filling up the lumen. Okay, filling up the lumen, and it is covered by the epithelial cells. But we can appreciate under higher power. Okay, this is the true fibrovascular core. You can see the true fibrovascular core, and the lining of the core is having two tiered epithelium. The inner is the luminal epithelial cells and intact myoepithelial cells. Okay, and this, the typical of this intraductal papilloma is when we did P63, it is positive at the periphery and the within the fibrovascular core. This is the indicating of this is the typical finding in the intraductal papilloma, indicating benignity of the lesion. So based on the Yokohama system, how they define the atypical. So the atypical is defined by the presence of cytological features that seen predominantly in benign process, with addition of some features that are uncommonly seen in benign lesion and which may be seen also in malignant lesion. So what are those features? Those features they highlight as prominent single intact cell dispersal, nuclear enlargement and pleomorphism, high cellularity, necrosis, mucin and complex micropapillary and cribriform architectural pattern. And the risk of malignancy for atypical is about 13 to 15.7%. However, a definitive diagnosis of malignancy on nipple discharge cytology is rare. Usually we just comment on atypical. Just to recapitulate a salient point about intraductal papilloma. So it is a benign breast lesion arising within a duct in a central, what we call as solitary, or in peripheral. It can be multiple location, and it is composed of papillary projection with fibrovascular core covered by an epithelial and myoepithelial layer. So the patient present with over a wide range of age, most commonly affected is 30 to 50 years old, and frequently present with unilateral nipple discharge. Radiologically, it is a well circumscribed retroareolar mass and can show solitary retroareolar dilated duct and rarely also can have microcalcification. So benign central papilloma without atypia is associated with twofold increased risk of subsequent invasive carcinoma, and it is about threefold increased risk with presence of peripheral papilloma. Okay, we go to the case number 4. This is 73-year-old female with underlying diabetes and hypertension. Initially, she presented with left breast lump in 2015, and after that, she was under yearly surveillance. So the biopsy was done in 2015, where the biopsy reported as intraductal papilloma. However, there was no surgical excision was performed after that. So subsequently, the same lesion was repeated biopsy in 2017, and it was reported as fibrocystic change. And after that, she was planned for yearly ultrasound follow-up. However, patient defaulted, and the latest ultrasound mammogram show in 2020 last year shows an increasing size of left retroareolar lesion. They suspicious of Barrett's 4. So because of that, they proceed with FNAC. Okay, this is under low power view. You can see based on the approach just now, we see the cellularity. So this is very high cellularity. So based on the architectural tissue pattern, the pattern, you can see there are quite many irregular large tissue fragments, and we can also see a single dispersed single cell pattern in the background. Okay, and how about the background material? Is there any mucin? Some background looks like dirty background, but it's not. There's no mucin or necrosis can be appreciated at this power. So we focus on the large tissue fragment just now. So this is the papillary core, where it has a thick, it shows a thick stellate-like papillary tissue fragment. So this is the thick fibroelastotic stroma. See, this is a big fibrotic stroma, you see, and the top of it is attached is the sheets of ductal epithelial cells attached, and under higher power, the other view, we can see that there is a bulbous tip of capillary loop, and it shows, it is called as a glomeruloid-like structures. Okay, then the covering cell on top is quite bland looking, and it doesn't show any significant pleomorphism. Okay, you can see this other group of clusters. The cells are more of columnar, but there is mild to moderate pleomorphism can be appreciated from these clusters, as well as the background of foamy macrophages can be seen. So we see on the higher power view, the plentiful dispersed cell pattern. So the cells are quite moderately pleomorphic. Some of the cells are bland looking, round to oval nuclei, and some shows very minute nucleoli. Okay. So based on that features, the cytology diagnosis is more definitely is malignant because more of the cellularity, the architectural pattern is more of malignant pattern. So the features of malignant papillary neoplasm of the breast. So what are the features? As I mentioned just now, we try to apply the cellularity architectural pattern as well as the background cell. Okay. So after that, they proceed with mastectomy with axillary clearance, and grossly the tumor is about 2 centimeter. It's solid and cystic. So this is under low power view to show you the expansile nodule. The lesion is quite expansile, okay, and composed of solid proliferation of epithelial cells with fibrovascular core and some of them having intratumoral branching vessels, but it cannot be appreciated at this low power view. So this is the papillary architecture. Okay, you can see the lining cells are columnar with not that great atypia, but there is low to moderate nuclear atypia can be appreciated. Hardly we can see any mitosis. So this is the other more preserved area that I've taken the image. Okay, you can appreciate the blood vessels, intratumoral blood vessels, and the cell is very bland looking, and hardly we can see any mitosis. The diagnosis, HPE diagnosis given was solid papillary carcinoma. So looking into the cytomorphology of papillary breast lesion just now is actually very broad, and it's comprised of very variable morphology from benign up to high grade, low grade to high grade malignant. So the criteria for benign and low grade malignant features cytologically, of course, is overlapping, and you can see that a definite cytological diagnosis is not always possible. As the previous case, the cellularity and the pattern is more prominent, so the malignancy can be strictly applied. However, we cannot subtype the type of papillary based on cytologically. So this review article actually interesting. They review all the retrospectively all the ductal papilloma in both benign and malignant. So they came out with a summary. What is the pattern, cytological pattern that available that they identify in intraductal papilloma. So basically, those features are very much overlapping. So very difficult to differentiate because both features are very much overlapping. The only differentiating features that really helpful is based on the pleomorphism as well as the cohesiveness of the groups, and also presence or absence of myoepithelial cell. The areas that may help in differentiating. This is the cytology features for papillary carcinoma. So as I mentioned, the features may overlap. However, this usually for malignancy, the material usually is more of abundant with a bit with areas of a bit loosely cohesive, and dispersal cell pattern is more prominent, and myoepithelial cells are usually absent. So they describe all the pattern that they analyze the cases for papillary carcinoma. So I just put my summary. Basically, what is the key cytology differences that helpful for us to differentiate, to decide whether this is a benign papillary or this is the malignant papillary. So for benignity of the lesion, usually it is more of cellularity is low. The groups of ductal cell usually still cohesive with low SU ratio, and the papillary-like tissue fragment lacking of fibrovascular core as compared to malignant type. And the cells, dispersal cell epithelial cell may also be seen in benign papillary, but usually more of columnar cell types. And bare nuclei, it should be present more of moderate to abundant. In contrast to papillary, in contrast to malignancy, features cellularity usually very much high, and the papillary tissue fragment with usually present with true fibrovascular core, and the dispersal single cell pattern shows moderate to marked nuclear atypia, the high NC ratio, and the other one is the bare nuclei. It should be absent and sometimes also may have necrotic debris. This is my just highlighting the constellation of features that actually help us, very much help us to decide whether this is benign or this is favor of malignant. So this is my last slide. Just to recapitulate salient point about solid papillary carcinoma. These carcinoma are an indolent tumors characterized by a solid growth pattern with delicate fibrovascular core. The tumor often shows neuroendocrine differentiation and mucinous components, and any part of the breast may be affected, but the central and subareolar area is the most commonly affected. It occurs primarily in the postmenopausal woman with a mean age of 7 decades. Radiologically, the lesion appears as lobulated, heterogeneous, circumscribed mass with or without classification. Typically, this lesion is ER positive and HER2 negative, and the prognosis is excellent. So this is my reference. Okay, with that, I end my presentation. I would like to express my gratitude to Dr. Pavin and all the cytology staff in Hospital Sultan Abdul Halim for their kind helping me to prepare the material for this presentation. With that, I thank you.